Hi, my name is Jessica Nelson, and this is the Mental Health OT podcast. Today, we're going to be interviewing Kelli Daller. Kelli is the current Mental Health Occupational Therapy Fellow at Johns Hopkins. She graduated with her bachelor's degree in kinesiology and received her doctorate in occupational therapy from Huntington University. She has experience in adult forensic inpatient mental health and is interested in occupational justice, forensics, and intersectionality. Welcome, Kelli. Hello, Kelli. Welcome. Thank you for joining us.
Yes, thank you for having me.
All right. So as I mentioned previously in the introduction, Kelli is currently completing a mental health fellowship at Johns Hopkins. How's that going?
It's good. I am about halfway through at this point. So I love learning from everyone that I've met so far and who have been my mentors. It's definitely a challenge at the same time.
Mm-hmm.
That was, the whole purpose of doing this fellowship.
Yeah, for sure, for sure. It seems like a really awesome opportunity, and we can get into that a little bit later in the episode. But first, I kind of just wanted to start out by asking, in your own words, how would you describe OT to maybe listeners who have never experienced OT or never heard of OT?
OT, I think of as we help people with the things they need to do, have to do, and want to do. So many different things in life can happen, whether that's physical injury, mental illness, that get in the way of those three things, our everyday life, our everyday occupations, which is why it's called occupational therapy. It's what takes up our time, what occupies our time, and we want to help with that. So that's my go-to. Delving in further, it's like anything from brushing our teeth in the morning to trying to find a job to helping care for yourself or kids. So, yeah.
Yeah, very eloquently put. I know that it's not always easy to explain what OT is. One, because our field or our discipline is so broad, our scope is so broad. We cover a lot. So
Yes.
I always kind of struggle, and I'm like, oh, well, we do this, but then we also do this, and it looks like this, but it also looks like this. And then I see people's eyes just glaze over like, why did I ask her this?
Yeah, exactly.
So it's like, oh, I need to refine this a little bit more. So I don't know if you've had this issue, but I've definitely had this issue since I began working in mental health, where I tell people I'm an OT, and then I follow up with, and I work at like a psychiatric hospital, or I work in mental health, and they're like, how does that relate? Like, I don't understand OT's role in mental health, this and that. I just wanted to see if you could speak to that, and like, what do you say when people are like, well, do OTs actually belong in mental health? What are OT's roles in mental health? What does that look like?
Definitely. And I think about the audience who's asking. So if it's sometimes it's other OTs who aren't in mental health who are wondering, so then we can delve a little bit
right?
further.
Yeah.
So when that's the case, I kind of refer to our OTPF in occupational therapy by AOTA. It has this great list of our occupations, which include ADLs and health management, medication management. So you can really break that down and say, having a mental illness, depression, anxiety, schizophrenia, bipolar, etc., really affects each of these occupations that we help with. Like if you can't remember to take your medications, like medication management, we can come in and help with that. If your illness symptoms are so severe, you're having trouble with ADLs, we can help create a schedule or establish a routine with you. So that's kind of more like my OT response, I guess, when someone kind of is familiar with us.
Yeah.
Outside, when it's someone else who's not as familiar, I would have a little different answer.
Yeah. So I'm curious to see how you respond to people who aren't OTs and who are kind of just out there. But really quick, I just want to touch on something you said, which I totally agree. Having mental health problems, whether you're diagnosed with a mental health disorder or you're just struggling with mental health in general, definitely does affect your participation in ADLs, which those of you listening who don't know what ADLs are, they are activities of daily living. So those are kind of just like those everyday self-care activities that we have to do. So like Kelli mentioned, like brushing your teeth, washing your face, bathing, toileting, stuff like that. So I do agree that mental health problems do affect that. I'm curious to get your take on how a psychosocial OT would maybe target or treat those deficits differently than, let's say, a physical rehabilitation OT. Like we're both targeting the same occupation, but how does the diagnosis or the problems that the client is having affect ways you approach that treatment?
Yeah, a couple things with that. One is depending on the acuity of symptoms. Sometimes it's just getting occupational engagement, getting someone to get out of bed, to just come and engage and eat a meal and be social with other people. So I feel like we kind of have a different lens with psychosocial at times, where our main goal for the day might be 15 minutes, like socializing with other people. Also thinking about, at least my experience, I've in the field, my small time in the field so far, I feel like we've learned a lot about CBT, kind of more of these broader psychology ways of approaching patients and having that lens as well. So really thinking about being client-centered, but also using all different areas to
and also I think a big problem too is just people's opinions or people's perceptions of occupational therapy is in the like scope in which they've seen an OT work. So like if you're a teacher, you see school-based OT, and that looks completely different than if you're like in an outpatient ortho right setting where they're just kind of working on hands and fine motor and stuff like that, versus if you're in acute care and OTs are the ones who come in and get you to sit up and wash your face off and other things. So yeah, I think that it's because our scope is so broad, people see us in so many different settings, and then that's kind of like their association with OT.
I agree.
Which can't blame them. So, okay. So I kind of wanted to just get into getting to know more about you and just why did you choose to pursue a mental health kind of.
So I knew mental health was something like that would be an interest, as well as I've always had a forensics interest. So when I found out, just researching the field of OT, that it was an option to be in mental health or to be in forensics, like I kind of went into school thinking like that would be my specialty.
Okay, so you kind of decided this before you even like started going to OT school.
Yeah, when I was applying, I was like, this is my biggest interest. I did go in with an open mind because you just never know like what else you'll find interesting.
True. Yeah. No, that's really cool. Can you explain to people who may not know what forensics is and what a forensics setting is?
Yeah, in forensics, that's someone who is also, for lack of a better term, intertwined with the justice system, the criminal justice system. So, for example, at like a forensic hospital, forensic psychiatric hospital, these patients have an alleged charge, and a mental illness has gotten in the way of them being able to defend themselves with this charge, which is one of our rights, the Sixth Amendment in the Bill of Rights here in this country. And so forensics has anything to do kind of with criminal justice system and how healthcare intersects with that.
Okay. So from what I understand, occupational therapists can work in a forensic setting, and they can work kind of through like a more mental health needs service, or it could be other maybe more ortho type needs or anything like that. So there's different services that OTs can provide in the forensic setting, but for your interest, it's providing mental health in the forensic setting, mental health care.
Yeah, I realize I just specifically talked about one area, which is with the
no, you're good.
crimes. You're good. But there's also like so many like jail prisons, people who have been charged with a crime already and are just serving a sentence. So it could be anything from finding purpose with like being in a forensic setting to helping people like be ready with life skills when they need to reintegrate into the community again.
Right. Yeah. Yeah, for sure. There's a lot of opportunity, I think, with that population. I know that you did a capstone regarding kind of like the forensic setting. So do you want to talk on that?
Yeah. So with the occupational therapy doctorate degree, there's a capstone project usually associated with it. And each school has their own version of the capstone. But with mine, knowing that I still wanted to specialize in mental health and possibly forensics, I sought out any program that would kind of take me on as a capstone student. So I found one through another university that was very gracious to take me on as their capstone student in community correction. And so this population of people were serving out the last 2 to 3 weeks typically of a prison or jail sentence. And they were here in this community corrections facility to learn some life skills, kind of get something under their feet before being released and out back in the real world and having to do everything on their own after being institutionalized.
Yeah. 2 to 3 weeks is a very short time to be teaching people social skills who have been locked away for who knows how long. So I guess my question with that is, how did you maximize like efficiency, and like how did you just maximize your time with this population to make sure that you were able to provide as much care as you could to prepare them?
Yeah, it was the contract, I believe, with this facility was 2 to 3 days a week to have OT on site. So it was a lot of groups and group therapy. We would have life skills groups, which ranged from financial management, nutrition, health management type, employment, like how do you apply for a job? How do you interview for a job? And kind of those IADLs, those like instrumental activities of daily living. And then we also could offer some individual like one-to-one sessions. All of these are optional to the people at the facility. So it was kind of like whatever you feel like would be useful to you, what you want to take advantage of. It was very client driven in this setting. I was going to add on that usually clients did have like 1, maybe 2 specific goals that they like were like, okay, I want to get like this accomplished. So that really did help drive like the sessions to like utilize the time best. Like, okay, what is your priority like while you're here? What do we want to accomplish?
So past your capstone, what other experiences have you had with this population?
Yeah, so after my capstone and passing the boards and graduating, I got my first job at a state psychiatric hospital, and I worked in the forensics department, where there were 2 separate programs there. One was called NGRI, or Not Guilty by Reason of Insanity. And these were the patients that were there for longer term, usually 5 years or greater. On the other side was our competency restoration program, usually patients being there for up to a year. And so that was my very first OT job.
Yeah, just getting thrown right into it. So I guess just curious, what does the journey for one of these clients look like? Like how how do they get sent to a facility like this? And then kind of like what is the difference between NGRI and competency restoration?
Yeah, so each state does it differently, or has their own version of this. So this was in Washington State, and their NGRI, the Not Guilty by Reason of Insanity program, I'll actually touch on that second now that I think about it, because first they usually have to go through a competency restoration program. So again, this person usually is diagnosed with a mental illness, and these illness symptoms are getting in the way of the occupation of going through the criminal justice system, of being in court, being able to sit through court, to have the coping skills, to have the effective communication skills, to go through the court process. And so coming to the competency restoration program, a big goal on the medicine side is getting medications adjusted, getting kind of those acute illness symptoms stable. And while they're there with occupational therapy, they'll go to groups. They will be seen one-to-one on occasion, and just getting kind of those communication skills, coping skills, illness management education. Because some people come in and don't, like, what is bipolar? I was told I have that at diagnosis. I don't even know what it is. So sometimes we start at the very basics. Once found competent, which is through a forensic evaluator, a psychiatrist or psychologist, I'm not sure exactly which, they will return, go through the court process with the charge, and then depending on the outcome of that trial or their court process, a very small amount will have the NGRI plea. So the not guilty by reason of insanity plea. It is very strict. There are a lot of rules to be able to plea that in court, but the main one being you have that previous history of mental illness getting in the way of knowing right from wrong. And so if a judge approves this plea, then they can move forward with it.
Okay. So I think my question is, let's say they go through competency restoration and they're found competent, so they're kind of managing their symptoms, stuff like that. But during the time of the, let's say, crime, they were not competent. So can they plea not guilty due to reason of insanity, even if currently they have restored competency?
Yeah. So they have to be competent and able to plea the NGRI plea. They have to understand
anything. Okay.
Yeah.
Gotcha. So when working in this setting, we kind of talked about the population that you had served. What was like a day-to-day for you?
Yeah, kind of the day typically consisted of teaching anywhere from 2 to 4 groups, facilitating those groups depending on just what is needed at that time with the population. It was meant to provide structure as well, kind of, again, staying occupied during the day to learn about occupations and helping the clients understand, first of all, like the reason why they are where they are, because as we just talked through, can be really complicated and confusing. So helping them understand, orient to what they're at is one of the groups, kind of that courtroom knowledge. Illness management is another group. So talking a lot about, that includes medication management, that includes things we can do to manage our health, like healthy choices we can make, talking about both mental health and physical health, going through those different things. We also focus again on that effective communication. That's a really common topic in mental health OT I found across settings, is talking a lot about effective communication to, again, we communicate all the time with people, whether we want to or not. So working with clients on that has been really important. And then coping skills to deal with the stress of what brought people to the hospital, the stress of being in the hospital, the stress of what comes in the future at the hospital. And so sometimes we would teach like all 4 groups based on those things in a day. Sometimes it was split up, but a lot of group focus within the mental health system in this job. Then sprinkled kind of throughout the groups was when a patient would request a one-to-one to really focus on something particular.
Okay. When they did request a one-on-one, was it something kind of particular to like that group, or was it maybe something different that they were also struggling with?
It could be. And sometimes we would really focus our one-to-ones for the patients that didn't come to group, that didn't feel comfortable in a group setting, like being around all those people, just being able to meet with them a couple times a week outside of that. So we would review like what we did go over in group. Here's what we talked about, and just talk to them about more specific, one-to-one, more individualized.
Yeah. So during your time working in this setting, I'm curious to know, I guess, in your opinion, what you think worked really well, but then also like some of the drawbacks, maybe some things that didn't work so well and that could maybe be modified or changed to provide better care or treatment.
Something I think that do work well is we are covering topics in group that are applicable. Almost like every patient, I want to say, not all, but almost like I believe did come away with something, with some bit of knowledge, with some way of thinking about like how to approach the situation they're in, something to take moving forward, as well as even just showing up and being that supportive person. I think in that consistency and reliability, like really is helpful to everyone, no matter what population you're in. So I think that was really like gratifying and really like grateful to be able to have like a small role in someone's life like that. On the kind of opposite side of things, I think a lot of times, kind of going back to our earlier conversation, OTs and mental health is a little unknown. It seems a little like the lines are blurred between different disciplines and what we provide. And so sometimes people don't know what all we can do because we are so broad and so holistic. I think we have a giant set of skills that we can provide for many areas of life and many areas of occupation. And so I felt a little pigeonholed at times where it's like, okay, your job is just to do like these 4 things or teach these 4 things.
Right.
And I think as OTs, we can really use our creativity and be a lot more broad and a lot more holistic than sometimes the system allows you to be.
Just being more specific, what are some examples of things that you would have liked to do or help with in order to support the client's recovery that maybe you didn't get an opportunity to do?
And of course, there's a caveat, like it is a forensic system, so there are a lot of like rules and laws going with it. But like some things I wanted to do was to incorporate more like leisure engagement activities and the importance of having healthy leisure, because a lot of these clients came from areas where leisure didn't look healthy for them or led to a lot of consequences. And so being able to like explore different things, like it'd be so cool to do anything with gardening or music or cooking or just like anything that can expand on that. And we're so limited in a forensic setting that made it hard. A couple other like coworkers and I even developed some like ideas and plans and programs with safety kept in mind. And like the time I was there, it still wasn't happening. So that was kind of hard.
Right. Yeah. Kind of putting or being motivated and inspired to provide better care. And then I know, especially in kind of like a government type of facility, it's just like change and like innovation is just it. You want it to happen, and I think the people around you want it to happen, but because there's so many policies and procedures, it is so slow.
Right.
It's truly so slow.
Mm-hmm.
Yeah, so I feel you on that. So as far as I know that you said kind of developing, you're obviously like limited because of the setting you're in. And so you take into consideration safety, which is important in that setting. What kind of things do you consider whenever you're designing a group, especially for this population?
This is thinking about forensics. Sometimes even the supplies that you have for a group is very limited, and it's hard because you want to be able to do just kind of typical groups, but even thinking about, scissors or pens or markers or anything that may not be allowed on the floor, or you have to supervise like every single item you do bring. So for designing groups, it's really thinking about, okay, what supplies can I have? What does the space look like? Will I be on the unit, on the floor, or am I going to be bringing them down to our treatment center, which is more classroom based? And so definitely the environment and supplies is like really up there for designing groups. And then just trying to be creative with the topics that we do focus on. So using kind of a topic as an outline, but then getting still as creative as possible to incorporate games or incorporate fun, and remembering like all of us adults are big kids at the end of the day sometimes. And so trying to change it up.
Right. Yeah. Well. I could imagine. Yeah. I can imagine some of those groups, the material is pretty dry. So it might not be the most fun or engaging kind of sitting there listening to a lecture about stuff like illness management and recovery. And I think too, with like me working in a mental health setting too, engagement is so important. And like I've learned since starting my job, it's not exactly what you're teaching, it's how you teach it. Because you can get buy-in with the most boring material ever, but it's just like, it's how you deliver it, it's the energy you bring, it's the way you relate to people, kind of like spinning it in a way where they, like I said, like, yeah, they can relate to it. This directly relates to your life because of X, Y, Z. Like making it applicable for them, and just trying to make it somewhat more fun. Honestly. I think honestly, like that is like the biggest thing. And personally for me, I have not been practicing for a very long time, but I have noticed a lot of my colleagues, which they are so kind and they are so helpful, and I appreciate them so much. But a lot of times I'll be kind of like making my own materials for group, and they'll be like, oh, like, why are you making this material? Like, we have like a binders for like that or that or that. But like, in my opinion, I feel like when you spend time really like making the materials, you can really personalize it to your clients, and you can really think like, well, I want to word it this way because that makes it more engaging, or like, I want to do this because I know so and so likes this, and so if I add a question about this interest, maybe they'll have more buy-in or this or that. So it's that balance between, because obviously if you make your own materials every single time, that takes up a lot of time, and it's super convenient when there's just like a binder of like, this program is already ready to go, but it can be dry then, and it can be kind of like not as applicable and not as engaging, which I've said a million times. So, and honestly, when I make my own materials, I'm just so much more excited to present it. And I'm so much more confident with presenting it because I know exactly what it says. I know exactly like what I was thinking when I did it. So I like making things hard.
And I agree. Like, there's something about, like, just like you said, when you make it yourself, like, it's personal to you as well. So kind of, the purpose and the end of the idea of the group. And that's something I'm like rediscovering right now in this fellowship. Because I've been being mentored by so many great people who have really great ideas and so many that I've never thought of before. So they've been kind enough to show me like their binders and their materials. And so now I'm in the process of like, how do I take this great topic, but now make it my own? And how do I add to it? And how do I create my own? So I'm in that process right now myself.
Yeah. So yeah, we kind of talked about on the micro level, I would say, just based on like where you worked, your opinion on, kind of the setbacks and like how to provide better services. But yeah, I wanted to talk on a macro level, just systemically, some of the drawbacks to providing quality healthcare for mental health patients, and just some of the things we as clinicians should consider, so that we can ensure that we are providing that good care to patients.
Definitely. There's so many things, of course, with this. One thing thinking about mental health is still so underfunded in general. So that's something I think like macro also just mental health being underfunded. Mental health still has such a stigma to it as well. And so I think really doing our job to like help break those stigmas, whether it's from other people thinking about mental health, whether it's self-stigma with mental health, and really like making it normal to talk about, making it normal to treat. And I think like you shared before, like even we're explaining what we do to others, like just kind of making that a normal conversation, and it doesn't have to be like, oh, what do you do? Like, why? And saying like, this affects a lot of people. And so just continuing the conversation is so important. And then on top of that, thinking about like who is disproportionately like affected by these systems, who is typically doesn't get good healthcare in our healthcare system, and who typically like is seen more in our justice system. So just thinking about, us like as clinicians, our clients don't always look like us or come from our backgrounds. And so how do we have that cultural sensitivity to really like see their point of view and understand like all the barriers that others have that not everyone has in mental health.
Yeah, I think that is really important. And I know from a previous conversation, we kind of talked about how typically occupational therapists are middle-aged white women. And on top of that, where I work, everyone thinks I'm a child. My age is of constant conversation. So yeah, I think that it's definitely difficult for me to walk in to this setting, and I've lived a pretty charmed life. Not to say that I haven't had like hard times or this or that, but I mean, my life looks completely different than the patients I'm serving. And we've actually had like conversations where it's been like, well, like, how, or do you respect like the people coming in and talking to you guys and teaching you guys if they haven't had the same life experiences? And a lot of times the answer is, well, no, not really, because like they don't get it. And rightfully so. So I guess like in your opinion, how do we address that, and how do we, I guess, build our knowledge? And even whenever we are knowledgeable about that, how do we put that into practice?
I think acknowledging it is obviously going to be like the first step for anyone. Acknowledging like, yeah, the privilege we carry, and just as you said, like being like middle class white women, sometimes as young providers too, we have to like understand that we have like knowledge with our young age, that we have like gone through the learning to know what we know. But I think just being transparent and upfront and saying to a client, how do you feel the fact that, we don't look the same, we don't come from the same culture, we don't have the same life experiences. Like, how does that make you feel? Sometimes you have to build, I would say, rapport. Like, you don't always need to start off with that conversation.
Right. You don't walk in like, I know I'm white. Tell me how you feel about it. No.
Some people might be cool about it. But just like just like sharing those thoughts in a professional way and
Mm-hmm.
seeing if there's something you can, a middle ground you can come to, and being ready for the answer no matter what it is. Because in like inpatient settings, which is what we work in, like they don't necessarily have a choice who their provider is. And so
Right.
it's like, how can we come to an understanding with each other? As well as even when teaching group, when we're not having this one-on-one like dialogue with patients, a lot of times with like mental health, like I encourage people if they feel comfortable to share like their experiences or share, my community, we don't even talk about mental health. This is the first time it's being acknowledged, or this is why it's hard, and just really validating experiences as well as continuing to do our part to keep learning from them as well.
Yeah. No, yeah, that's a good point. Kind of like creating that safe space for them to express like their lived experiences, but then also like you taking steps when appropriate to acknowledge the fact that like we're different and that's okay. And I want to hear how you feel about it, and I'm going to consider that when I work with you. And yeah, I think that's really good advice.
So just
Yeah.
and showing that we care.
I also kind of wanted to touch on too, and it goes along with this. Whenever you're working with clients who come from different cultural backgrounds, who typically don't talk about, mental health, they don't talk about their emotions. What would your advice be when working with clients like that to kind of get them to open up and to maybe, I guess, acknowledge and respect that cultural difference, but then also, I mean, they're in a mental health setting and we're mental health OTs, so we still have to work on it, and we have to, kind of, while respecting it, teach them still and work with them and provide care. So like, what does that look like?
Yeah, I think really having a collaborative approach and sharing like, okay, we are in the hospital, like you're in the hospital, mental health hospital. So we really have to think about like, why are you here? Like, what are those events? And I think just acknowledging that it is hard to talk about, like it's hard for everyone to talk about emotions, even if it is your job to talk about emotions. It still is not easy to share your own emotions and be vulnerable. And so just really validating that and validating that it's going to be a hard journey continuing forward, because we hope this is the first time they're understanding emotions and talking about them, and it will continue to happen for the rest of their lives, hopefully. And this is also where group therapy really does become beneficial, because there's usually other people who can like understand and agree and say like, oh, I totally get it. Like I felt the same way too. And so I've really have had the privilege to see people open up with each other in group and really see like some amazing moments that people have and support that they give to each other. And so that is really like the huge like benefit of doing group therapy as well.
Yeah, that's a really good point. I guess because when you kind of see other people who you could probably relate to more than the person facilitating the group open up and be willing to, I think, yeah, that definitely supports maybe doing something that might be a little bit uncomfortable and being okay with it. One of the other things I kind of wanted to talk about too is just as like a mental health clinician, I feel like we have a lot of power. I would argue that working in mental health and working with this clientele, we're probably working with the most vulnerable people. And I feel like gaslighting could definitely be a thing that we could maybe do, but not even like realize we're doing it. So yeah, I just wanted to open up that conversation of like, I know for me, I've realized throughout me documenting how important it is to not, I guess, interject opinion and interject maybe those biases that I might have or those assumptions that I might have. So like if you're talking with a client and they are telling you that, I don't know, some outlandish fact about them, they have like, they've lived in, I don't know, some unlikely place, right? Any unlikely event. Then I'm kind of like, okay. I know I've realized that it's really important to not say client is delusional, X, Y, and Z, but instead just put like quotes, like report on like objective information. Like this is what happened. This is what was said. So like really just like fact-based documentation, which I think that in other settings, I think it's safer in other settings to make a little bit more inferences. And that's just my opinion. And yeah, I just feel like I've had a lot of, I'm trying to think of the word, maybe it's like discomfort or just like ethical dilemmas while I try to figure out what to document and what is fact-based and what's like impartial to like, I think that this is happening, but I don't know. And I don't have any proof. And like, I'm not a psychiatrist. I don't diagnose. And then even with the diagnosis, how important is a diagnosis? Exactly. Because I think when we look at a diagnosis, that kind of puts blinders on for us. And we are kind of like, oh, they have schizophrenia. So they are, anything they say could be like they're hallucinating or like they have psychosis. So everything they say, they're gonna be delusional. And so already coming into that with that mindset, I think is dangerous. I know that I just like word vomited all of that, but like, what are your thoughts on that?
Yes, I definitely like had all of those same thoughts with like the diagnosis part. I know like we know the reason for it, and like in order to get treatment, you need a diagnosis and to like guide a lot of like medication treatment is what I'm thinking. Like psychiatrists are using their diagnosis to guide what medications to try and this and that. But as OTs, yes, like it can be useful to know what could be going on with the client, but everyone looks so different and is so individual, and there's so much blurred lines between different diagnoses. You can even see like bipolar with psychotic features, which means they might be having hallucinations and delusions, but a bipolar diagnosis. So it's like, how's that different than a schizophrenia diagnosis where they have hallucinations and delusions? And so if we focus more on the person that's in front of us and less on the diagnosis itself, that's something I've really tried to do and tried to focus on. I think I said focus like 5 times.
No, it takes focus. It takes focus.
Yes. With the documentation, thinking about it is different, and it's something like I still catch myself doing, which is somebody is distracted in group. They're not focusing. They are doing what could be, we think, is internal like stimuli. Maybe they're hearing a voice or seeing something. Who knows? Maybe they're just bored and staring off in space, though.
Truly, like we just talked about how dry this information can be.
Yes, it can be very dry sometimes. And so we don't know. The best thing we can do is just say what we saw. So they were staring off into space. They were like, as evidenced by this and this. Sometimes I still say like appeared to be like engaging with internal stimuli if it seems really obvious to me.
Right.
Which can be like, and then I explain why in the documentation, like they were talking to themselves. They were saying this to somebody that there's no one else there. But at the end of the day, we don't know unless we ask them like what was going on.
We don't know. Yeah.
Myself all the time. So
truly. And that's, oh my gosh. Like it's, like half the things that like I notice that people do, I'm just like, I would probably act the exact same way if I was put in that situation. So I don't think that's a mental health issue. I think that's just like the situation they're put in. And
yeah, I think that ties well back into what we were kind of saying before is like the system we have now was like made to discriminate. It was made to not treat all people equally. So, of course, having more stressors in life and having more prejudices and having more to deal with, like, it's going to lead to possibly more incarceration, which can lead to more mental health problems, so it just is snowballing. And so, yeah, we don't know how much is situational versus genetics, which then goes into the whole other mental health, topic of we don't have like a gene or a test that can say you have schizophrenia, you have depression. So it's a lot of the environment and as well as genetics, we think. So it's complicated.
We think, right? Yeah. I think there's definitely problems in the mental health field. And I think a lot of it is the fact that there isn't a test where we can say, like, without a doubt, yeah, like you have this and that. Like, a lot of it is like informed speculation, if that's like even a thing. So it's like, it's tough because you never like really know. But I think that that's just like that mindset and that like humility, which like you've used that word, is like really, really important for anyone working in mental health. You just need to know that like you don't know. And at the end of the day, that's kind of where we're at in the field. Like you don't know for certain. And there's not really concrete interventions for certain to treat these disorders or these illnesses. And I think that's kind of too what I've been struggling with is just like, okay, so this person has this, but there's no roadmap to like, okay, if this person has this and you're an OT, you need to do X, Y, and Z to treat them and this and that. No, that's not it at all. It's just because someone has this diagnosis, you have to like really look at them holistically because one thing isn't going to fix it. It's just like this combination of everything. And it's looking at what are the values of this person? What are the supports of this person? What are they interested in? Like, why are they the way they are? Why do they think the way they think?
Yes, it is. And yeah, it can get really like philosophical and really like, does anyone help? Does anyone do anything? And so I've also like had to work through that. I would definitely say like stepping into mental health in an OT, especially like in a forensic setting or in an acute setting, like you're really seeing really severe symptoms and people coming in like going through their hardest times. And so sometimes you even have to take a step back and be like, OT might not even be helpful in this moment. Like you might just need some sleep and you might just need to get some food and like really kind of stabilize, talk to your medication, talk to your treatment team. Hopefully a medication will help, because when I've gotten to see kind of the next steps, when somebody is able to engage and somebody has that motivation to get better, to manage their illness symptoms, then that's when I feel like we really flourish as like OTs, is when we can show them, okay, here are some strategies that have worked for people. Sometimes it's hard to remember to do your whole morning routine. Like, I can't imagine having another voice in my head telling me to do other things while I'm trying to focus on my things. So let's work together on that strategy. And sometimes it's hard to, control our emotions. And so let's really focus on these interventions that have shown that do help people of all ages. And so it's easier to see sometimes when somebody is part of the way there already, when we can kind of meet.
Yeah, and definitely like, because you're kind of talking about acuity, our role definitely changes based on the level of acuity they're at. So like if they're like super high acuity, I mean, I would almost see that we more turn into like an acute care role of like, okay, let's walk outside your room and wash your face. And if you want to get back into bed after that, cool. Like just like tiny little baby steps. But then once they're farther along, that's where those more like psychosocial type strategies, I think really come out and shine, and like more focusing on like okay, what's going to motivate you, and like what's important to you, what reflects your values. Like, let's do some goal setting. Yeah, like let's establish routines while you're feeling well and try to like stick to it the best you can. And really just talking about like their diagnoses and like opening the floor to like the stigmas of them and like their cultural responses to them. So yeah, it is a spectrum in and of itself with like where we start. And it's just meeting the patient where they're at. Which is what we've learned since day one, I guess.
Exactly. Yes, since day one. Sometimes we're the only person on their treatment team to ask them about all these different things in their life too, not just about their symptoms, but like, yeah, what do you like to do for fun? Or what would you like to do for fun? Do you cook at home?
Yeah.
Like, what are all the things that you do that make you you? And so I think that's also where we can like shine a light on what makes someone who they are. Yeah.
Definitely. Because all those pieces matter. And they're all a part of mental health. It's so important.
Everything's connected.
Yeah, it truly is. So, but yeah, I want to shift gears a little bit and talk about your fellowship. So yeah, obviously super awesome that you're doing a mental health fellowship, but not only a mental health fellowship, but at Johns Hopkins. Yeah, I just wanted to kind of hear from you. Like, how would you describe a fellowship? What are the benefits of it? What have you What have you benefited from by being a part of this fellowship? Yeah.
And this is something I learned right away. I guess it's Johns Hopkins with the S. S at the John.
Johns Hopkins.
Yeah.
Johns Hopkins. Johns.
It was one person. You learn the history, like when you, oh, good to know. So in case anyone,
they don't play
from Johns, you know it's with the S.
Listening to this idiot.
They're like, oh,
no.
God, not another one.
There's more than one John.
I didn't even know until, well, yeah. Anyway. So
thank you for that.
You're welcome. The fellowship, I sought out further educating my experience in mental health just because my first job was in forensics, and I did love my job. I enjoyed all the patients and all the groups, but I felt like there was more that OT could do in mental health that I just wasn't being exposed to. And as a newer practitioner, I wanted to be able to keep learning and to keep growing and understand that. And so I honestly had a really good friend of mine do a fellowship in social work after she graduated. And so that sparked the idea that I wonder if OT has fellowships. Like, it's something I've never heard of, but I'm sure they exist. So I looked up specifically mental health fellowships and found quite a few through the AOTA website, our American Occupational Therapy Association. And so that's kind of like how my journey to like applying for it and going through the process. And so grateful that I have this opportunity of this 12-month fellowship. Yeah.
Yeah. I completely relate with you on you feeling like, you know, you're practicing and you love your job, but like you don't know what you don't know, but you know that there's more and that you could be doing more. And yeah, no, that's like honestly the boat I'm in now is like I love my job. I love like the flexibility of it and the fact that I can really do so many things with it. But like, what do I do? You know, it's kind of like, so yeah. And I think, and I don't know if that's just like maybe in school maybe psychosocial OT isn't like hit as hard as like other specialties. So like when you enter into settings that are mental health, you don't feel as prepared. Maybe that's it. Maybe it's also combined with I am a new OT, you're a new OT. So just kind of like that imposter syndrome. And then also just like the nature of mental health in general, where it's like you can do so much. And there's, like I said, there's no like direct path to like wellness and recovery. Like it's there's no
Right.
linear way to achieve this. And so like, how do you even begin to develop a treatment plan, and how do you even begin to decide what interventions you're going to use to treat these things? But yeah, so with that, I know that you're about halfway through right now. Yeah. So like, so far from like everything like you've learned, how has it, what are new things you've learned, and how do you feel it's going to impact you after you finish this fellowship and change the way that you practice?
Oh, yes. It has. I've learned so much already. And I definitely have felt like somewhat validated, I guess I'll say first off, because I was coming in with everything you also just said, like all these concerns about, do I know enough, this and that? And I've been validated, like, you are a new practitioner, you're not supposed to know everything. So like just hearing that, it's like, okay, that already makes me feel better. And even just being reminded that at the end of the fellowship, you're not expected to be an expert. Like you are expected to be better than before. Like that's the goal. And so just hearing that, it's like, okay. And it's really
progress,
taught me
not perfection.
Progress, exactly. So it's really taught me and is teaching me something I'm still going through and learning, like just how to be even like a better like initiator, finding the knowledge, or like how to like go through the process of asking questions and like reaching out for mentors, and just it's really opened my eyes to not just having like these what I consider expert mentors like helping me along the way, but really teaching me how I can continue to grow, because they're all continuously learning and all continuously like wanting to learn more and coming up with new interventions as well. So I'm like, okay, it's a journey. Like, it's not like, oh, one day I feel like I know how to do this. It's just going to be, I know a little more of how to do this. So those are like the overall themes that I've really learned so far, and I'll continue to learn. Kind of looking overall, I've gotten to have a lot more one-on-one interventions in this fellowship than I did in the forensics job that I had. So that's been really useful to kind of get to know each client, each patient that much better, to be even more client-centered and more individualized with goals. And I'm rotating through different services. So some, again, are more that acute presentation and that are there for just a couple weeks, just need to get restabilized. And so with that, we're learning a lot about if they're really acute, they're not doing their ADLs again, they're not showering maybe as much or eating, or so just kind of doing more what looks like acute care setting, like getting out of bed, washing your face, brushing your teeth, like engaging with other people when it's really acute symptoms going on. For other people, they are receiving treatment for many months at a time. So thinking more of those long-term goals that we can work on. For some people, it's knowing their job is the thing that was their main stressor that caused them to have more mental health symptoms. So maybe we can think about, can you ask for accommodations at your job? Are you looking into a new job? Kind of thinking about how can we change these stressors in your life? And then not only am I like learning a lot, these are still kind of like talk therapy based in a way, even though we're doing concrete things, if that makes sense. It's like thinking about jobs, thinking about what the routine will look like. But even just role playing, like practicing conversations with people, like what will that look like when you feel these emotions come up and you need to cope with them. And so mental health is still, it's a lot of the same themes that I've had before, but really learning how to expand on them, if that makes sense.
Yeah, no, it does. So as far as kind of like new interventions and kind of things that maybe you've been introduced to, what have you added to your toolbox from being in the fellowship? Like, I don't know. I know that sensory integration is kind of like a big thing in mental health, or becoming a big thing. I don't know if there's like kind of other examples you have, or.
Yeah, we do. I have learned a lot about sensory as well. We do a group in this position about using our five senses like as a grounding technique for coping with big emotions and coping with mental health. Kind of thinking about what grounds us, what energizes us through our senses. and how that helps. So that's been something I've learned a lot about and that I'm definitely adding to the toolbox. Talking about how important it is to have a balanced schedule. Something that I think some of us take for granted is like just knowing how to like plan your day and knowing what should be balanced. So I've learned a lot about creating a balanced schedule, which again, it might sound simple, but really breaking down the components, and we'll get burned out really quick if we don't have a balanced schedule. And so that's been ideal. Sleep hygiene has also been a big push. And so I've learned a lot about our role in sleep hygiene and educating on that as well.
Yeah. Yeah. And I like that you kind of added like clinician self-care, like with balancing your schedule and stuff. Cause I think especially, I mean, across the board, healthcare workers struggle with burnout and compassion fatigue. But like especially in mental health, and especially working with clientele who have such like heart-wrenching stories sometimes, and like you just feeling like, oh, I'm not doing enough, and like how can I help this person, and maybe not seeing like direct results from what you're doing. I think that just like expedites that burnout and that compassion fatigue and all of that. So yeah, definitely like taking care of yourself by balancing your schedule 100%. And I I definitely struggle with that since beginning to work. I just like I go home and I just think and think and think about everything at work, and I'm like, how do I stop thinking about this and obsessing about this? But yeah, I think it's just I need to take up meditation or something. So mindfulness.
Yeah, that's also been a great one. A great intervention we do with patients is mindfulness, meditation, like progressive muscle relaxation, visual imagery, anything that can be used as a coping skill to help relax. And just like we have burnout, like so many patients have had burnout in their life too. So nice to talk about them and relate to that piece of it.
Just curious, how is buy-in with stuff like that, like meditation and mindfulness?
Yeah, it definitely depends on like who you're working with, because it doesn't work for everyone. That's true. And I usually, if I'm doing a group with like any meditation or relaxation or mindfulness, talk about like, this is your first time trying it. Like it probably will feel different, and it's not like it doesn't come natural. Usually it takes practice for it to become natural. And so I just encourage like coming in with an open mind, and sometimes even talking about the science behind how it's shown to lower heart rate and shown to lower blood pressure and help across all age range populations. And I find that, you know, most people are willing to try it at least once. They're also welcome to say, you know, not my thing. Like, can we do something else? Or can I like just come back later? And it's like, yeah, that's okay too. So I think,
definitely not like forcing it on anyone.
Yeah, we're not forcing it on anyone. And luckily, most people have been willing to at least try it. So, and then sometimes they're like, oh, that was great. Sometimes they're like, I tried, but I won't do it again. So that's okay too.
Yeah. And I really like, and I totally agree with you with the idea of like giving them the why behind it. So like, it's not like this random intervention that I came up with that I think will work, but like, no, like I know it might seem a little weird and it might seem a little like out there, but like, this is what it's supposed to do. This is the physiological effect of it. It has been shown to help people in X, Y, and Z. And so, yeah, I think that is a really powerful way to create buy-in, but not only just create buy-in, to like really help our clients to be a part of, you know, their recovery. Because if they understand why we're doing something, like, I don't know, it makes everything so much better to me. And like, it just increases like their health knowledge. And I think that like in the future, if they understand like why it works, like they'll be more likely to apply it. And it won't just be like, oh, well, we did this one time and I don't know why they told me to do it, but I did it and that's that.
And that brings up a great point too, the applying it part, the applicable part, because I think that's where OT really can shine. And that's what I'm learning in this fellowship is like, because other people can lead a meditation, other people can lead, relaxation or yoga. But I think in OT, we really can share, okay, here's how you can continue it on your own. Like, so you don't need a facilitator. Like, how will it fit into your daily schedule? Let's break it down. Like, okay, you like go to bed at 10 p.m. Would it be helpful to do this at 9 p.m. every night? And like, what supplies will you need? Where do you live? How could we make this work? Here's the website you can go to. Like, so really the application
like making
part.
it more accessible.
Yes.
And like individualized and all of that. I agree. I definitely agree. So I think that as far as the fellowship, you've answered all my questions. Is there anything that you want to speak on more for the fellowship?
It's like such an all-encompassing opportunity. Not only am I learning from a lot of great OTs while I'm at this fellowship in different settings, like geriatric setting, pediatric mental health, which is just something I haven't even thought of like as a career, and really loving that opportunity. But also the outside of work, direct work opportunities that this fellowship has provided, like advocacy, going to Hill Day in Washington, D.C. with occupational therapy, talking to like legislators about the importance of funding OT, like through Medicare, Medicaid, which is what government, and even talking to like state legislators about mental health and OT's role in mental health. That's an area where I didn't know I would like or didn't really know much about. And so having that exposure has been really awesome. As well as there's a lot of like journals and readings and just didactic education. And so really just understanding the why behind why interventions work and why OT should be in mental health, like how it has shown to make a difference. And so kind of getting that well-rounded like experience. Yeah, it's been great. Busy, but great.
It's really cool. And I think that like advocacy to so many people, me included, just seems like this, it's intimidating almost, because it's like, in order to advocate, you have to understand what the current climate of OT and mental health is, what it looks like, what am I advocating for? I don't even know the issues. And like, I feel like everyone or I would hope that people who would want to advocate would have that base knowledge of like, well, this is what's important and this is what's like needed and this is important to advocate for. So what would be your advice on kind of like gaining that that foundational knowledge, and then moving from that foundational knowledge to advocacy?
And this fellowship is sponsored with AOTA, so the advocacy opportunity has been through them and their website. Looking up Hill Day, and if that's something you're interested in, you can go to the website and register. It might be too early to register for this coming one. It's in September every year. But they send out, really great information. They're kind of sending out what is in Congress, what bills to pay attention to. Not just through Hill Day, but AOTA has like a whole team that's there to let us know, like, hey, here's a template. You can just copy and paste and write your legislator. Like, we would like your support on this bill or not. So a lot of people are doing like all of this amazing work, and it just takes someone a few minutes to, copy and paste an email and put your name on it, or you can like edit it to make it more personable. So that's been something I've learned about a lot.
Yeah. And I mean, it's incredibly important. I feel like advocating for OT in general, especially because it's a field that's like, I feel like not well understood. I think that is kind of a duty for all OTs.
Right. I can't say that I currently belong because I don't know where I'll be living next, but there's also the state associations for OT as well. which also put on like local versions of all of these. And so that can be a really great resource as well. So look up your state association and see the work that they're doing. And just like with anything to do with, politics, take it with a grain of salt would be my advice. But usually the work that OT is doing is pretty great.
Yeah, totally agree. Well, I think that is all I have for you. I just wanted to say thank you again for taking the time to speak to me and be a part of this project. I hope that the people listening will hopefully find what we have to say a little bit beneficial, at least. But yeah, I think that you brought up some really great points and had really great things to share, and I just really appreciate you. But if you would like to say anything else before we end this, the floor is yours.
Well, thank you for having me. And I think it is helpful to talk to other like newer OTs as well, especially in mental health, because I feel less alone knowing like, okay, other people are having these same thoughts, are having these doubts, having these questions. And it can be hard to like find our footing, I feel like. So anything that can open discussion and dialogue and would be awesome is if like someone's hearing this and they have like experience, they can share advice. That would be really awesome. Also, just, these are my experiences. And so I could be wrong about, some things that I've learned or said or anything like that. And I'll continue to grow. And we all do as OTs in the field. And so I think that's exciting, is important to have that occupational justice component to advocate for clients both at work and outside of work. So continuing that.
Yeah, for sure. And yeah, I definitely second that. Like, I am early in my career. I have opinions, whether they are right or wrong at this point, I don't know. I'm still growing, I'm still learning, but that's just my perceptions at this point in my life. So very, very good point you made. Don't cancel me. So yeah. All right. Well, I am thankful for you, thankful for your time, and that is all we have today.